You will hear part of a consultation between a psychologist and a patient called Mr. Barry.
Hi there, Mr. Barry. Your GP has referred you to me to discuss your anxiety. So tell me, how have you been feeling?
Well, I'm still suffering from the anxiety and panic attacks, and the medication that I'm taking, I found that it seems to have some side effects and it makes me still feel a little on edge. So I found it better to take the medication at night rather than in the morning, and so I can get on with the day kind of thing, but I still feel quite anxious.
Okay. Getting used to the medications can be difficult. Going back, when did you start the treatment again?
Oh, what, 3 weeks ago now? And that was the citalopram, the one to hopefully control the panic symptoms longer term, and the chlordiazepoxide, which is for the more short-term control.
How many of the chlordiazepoxide are you using a day at the moment?
Well, the doctor gave me 20 milligrams 3 times a day, but to be honest, I'm trying to cut them out. I only use them if I really, really need them.
Good. And do you feel okay with that?
Yeah, it's like I don't feel like they suppress me enough, if you get what I mean. I know that my main aim to tackle this is, to be honest, is getting fit and more exercise because I know that's the feeling that I need to aim towards. Because I know from past experience that when I work out, I feel better, I feel more relaxed, etc. So I'm trying to work towards that.
So, how many actually are you having at the moment?
Today I've had to go into work just for a conference with my manager, just to discuss how things are going and stuff. So I had to take two because I just felt like I couldn't manage it otherwise.
Right, okay. So, over the past 4 or 5 days.
None except for the two today.
So, you've actually been laying off them altogether.
Yeah, I've been trying, and when I do take them, I only feel suppressed for a very short amount of time.
Right. Now, the citalopram medication.
Yes, I'm on 20 milligrams once a day, and the side effects, headaches, were quite bad to begin with, and I'm still getting them. But I think that could be more stress related because they're not very, I wouldn't call them painful headaches. I just can feel they're there. I also had a sore ear, so I wondered if I might just have an infection or something too.
Okay, we'll come back to that. But you're now taking the citalopram at night.
Yeah, I found that if I take it first thing when I get up, I still feel quite edgy, and also the side effects.
Yes, okay, right. Now, the reason you started the treatment was because you were getting full-blown panic attacks. Can you tell me a bit more about the attacks?
Yeah, well, I couldn't leave the house. My heart races and I really struggle to breathe, and I just feel an intense fear. It makes me feel sick and dizzy if I go out into the street.
You find it very difficult to get out and about. Are you beginning to normalize, do you think?
Yes, I've managed. I went over to the soup store on my own and I managed. I felt a bit jittery at first, but I've learned over the years after suffering quite severely with them years ago that you just have to take your mind to a different place and I just concentrated on what I wanted from the shop. That was the first time I've been out on my own since I started on the medication.
A doctor talking to Mr. Roy Daphnis about his planned hospital admission. For questions 1 to 12, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes.
So, Mr. Daphnis, this appointment is a chance for us to talk a little about your upcoming surgery and for you to ask me any questions you might have.
Okay, yes. Well, I don't really have any questions about the surgery itself. I feel I understand the procedure quite well from all of my reading, but I do have a concern. I'm actually quite worried about how I'll go with my eczema when I come into hospital. It's important for me to follow my usual routine, you see, or it will flare up again.
What is it specifically that you're worried about?
Well, I've had eczema for years now, since I was a kid. It's chronic, I guess you could say, and there are all sorts of things that make it worse. Like getting too hot, you know? Like I'm in a room and the sun is shining in through the window and it starts getting very stuffy or something.
Okay, we can make sure that you have a bed well away from any windows if that'll help.
Yes, that would be good. Thank you. As long as I'm in an air-conditioned room and it isn't too hot, that usually helps. I also notice that certain foods and drinks make it worse. I stopped drinking alcohol years ago because it always made the itching worse. But I also have a list of foods that seem to aggravate things. So I was wondering if it's possible to give that to someone, or if I can let the hospital know so that they don't include any of these foods in my meals.
If you contact the hospital directly, they'll be able to help you with that.
Great.
Tell me, Mr. Daphnis, what's your skin like at the moment?
Not very good. You can see by my face how red it is, and the itching and scratching has been much worse lately. I think because of the stress I'm feeling about the operation. It's also really bad on my back and my legs. When I lie down in bed at night sometimes I can hardly stand it.
Do you ever get any sores or weeping?
No, my skin is just dry and very itchy. But I'm most worried that because of the operation, any broken areas in the skin will mean I'm at risk of an infection. I'm doing everything I can to prepare properly though. Instead of showers, I've been taking lukewarm baths. And I never use any soap because it leaves my skin extra dry. I know using it removes the natural oil, so I use a soap substitute instead. I'm being really careful about the clothes I wear to be sure that they aren't going to exacerbate the itching. I really don't want to be scratching it at all if I can help it, and I've been using an oily moisturiser nearly every hour. I don't like to use a lot of those steroid creams and things, but I can if you think it'll help. I see a dermatologist sometimes and he said if I don't like using them, I can save them as a last resort.
Okay, it sounds like you're doing everything you can to manage the condition, but you do need to try and relax and make sure you're getting plenty of rest. I know that stress is only going to make the condition worse.
You're right. I know I'm probably getting worked up over nothing, and everything will be fine. I'm taking an antihistamine at the moment, so that's helped with the scratching, and I'm sleeping a bit better as well.
Part B. In this part of the test, you'll hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare setting. For questions 25 to 30, choose the answer A, B, or C, which fits best according to what you hear. You'll have time to read each question before you listen. Complete your answers as you listen. Now look at question 25. Now read the question.
Okay, your order sheet is in your chart. It's under the tab that's labeled Physician's Orders. You're going to check these orders against your paper MAR. There's 2 pages to your paper MAR, your routine medicines and your PRN medicines. So first check your patient's name, Sally Gunter, Sally Gunter. Okay, then check for the date of birth, 5/8/41, 5/8/41. The next thing you want to look at is allergies. Sally is allergic to penicillin. Your allergy is penicillin. And you want to go down and you want to verify every medicine that they have. So on the orders, it's potassium chloride, 40 milliequivalents, PO 3 times a day. Potassium chloride oral liquid, 40 milliequivalents, PO 3 times a day. K-Flex, 250 milligrams, PO every 6 hours. K-Flex, 250 milligrams, PO every 6 hours. Norvasc, 5 milligrams, PO twice a day. Norvasc, 5 milligrams, PO twice a day. Prilosec, 20 milligrams, PO daily. Prilosec, 20 milligrams, PO daily. When you're looking at your physician's order, make sure it has a date, a time, and a physician's signature. Sally Gunter also has a PRN order of clonidine, 0.1 milligram tablet every 6 hours, PRN for diastolic blood pressure greater than 90. Clonidine, 0.1 milligram tablet, PO every 6 hours, PRN for diastolic blood pressure greater than 90. Now all your routine meds and your PRN meds are checked against your physician's order sheet. The next thing you want to do is to look here. Number one is compare your order sheet to your MAR and then your initial once verified. So you would sign your initials that you verified these medicines.
Question 26. Now read the question.
Let's examine this. If I had the fearful thought that I could ultimately lose everything, then it's not going to move me forward. It's not going to help me think clearly. It's not going to help me, move forward and take the actions that I need to take. It can kind of limit me and make me feel like I don't want to do anything because I'm scared to do anything. But what I have found, and this is what I do all the time, is when I'm having a fearful thought, I know that I can't not think about something. Because the more you try to not think about something, the more you're just going to think about it. So you have to replace that thought. And what I replace that thought with is, how can I use this fearful thought or use this fearful event to make me a better person, a better nurse, and to learn from this experience? I'm happy to share this with you so that you can, hopefully learn from my mistakes. So what happened was I realized that I made the mistake, and not only had I made the mistake once, I had actually done it the first time I administered the medication as well. So I thought about it, and I was like, okay, well, of course I have to do an incident report. With the mistake, I'm going to show her that I can, not only take care of the situation and have her trust me with her patients, but she can also see that I'm a very confident person and that this mistake won't happen again. So I went to her and I said, I told her the mistake, ultimately told her what happened, and, it was a mistake, and we examined it, and, she asked me a few questions, and it was an uncomfortable situation, but what I realized was that I came out of that as well as I possibly could have. Having the lack of confidence, you can replace that with, no matter what happens, I will build from this, and I will learn from this, and I will ultimately become a better person. So guys, it's all about replacing those fearful thoughts with thoughts that are going to serve you.
Question 27. Now read the question.
I was actually talking about culture-bound phenomena, and I had a professor of psychology say to me that there's no evidence that culture-bound or cultural illness exists. And I actually said to him, my response to him was that you're absolutely correct. And people were quite surprised when I said you're absolutely correct in the world in which you live. So you actually can't necessarily blame someone if they've never actually been exposed to it before. So the important point is that if you actually don't have it in a framework that most people, and what I'm talking about is mainstream, can relate to, in that it's actually researched and it's written up in a scientific journal, then they're actually forced to relate to it, or at least open their, mindset up to a different reality.
Question 28. Now read the question.
Hello, I'm Jan Machescu. I called this morning.
Yes, Mr. Machescu, your prescriptions are right here. They've been ready for an hour.
Good.
Now, take these pills 3 times a day. That's every 8 hours.
I usually take them at 7 in the morning, 3 in the afternoon, and 1 before I go to bed about 10 or 11 at night.
That's fine.
When do I take the other pill?
You can take these any time you feel a pain.
Well, it's almost lunchtime. Is it okay if I take one before lunch?
It's better if you wait until after lunch, after you've eaten.
Well, why is that?
The pills may upset your stomach if it's empty.
Oh, okay. I'll wait till after lunch. I'll take one about 1 o'clock this afternoon. Well, thanks very much for your help.
You're welcome.
Question 29. Now read the question.
Right, I'd like to tell you about all the patients on this ward, starting with bed 1. John Smith is a 45-year-old male who had a motorbike accident on his way home from work. He was admitted to the ED at 2300 hours on the 1st of August with a frontal lobe contusion.
Sorry, I don't know that word contusion. Could you please explain?
Sure, in this case it means a concussion. Thank you. He has breaks in his right arm and hand and has had surgery, including metal plates inserted into his arm. He also has deep grazes on his left knee and ankle and stitches in his right hip and shoulder.
Stitches in the right hip and shoulder?
Yes, that's right. All dressings have been changed this morning at 900 hours. He's on a self-administered morphine drip and he's also on an antibiotic drip. He has had injections to prevent blood clotting and his pain is quite manageable with the medication he's on.
Question 30. Now read the question.
I worked with this man called Graham. That wasn't his real name. He started to hear voices. He had strong paranoid beliefs that people were talking about him. He had to come into hospital, and the main way of actually helping overcome that loneliness and isolation as a result of his experiences was to really enter his world, to develop a shared model, a shared understanding of how these experiences shaped his beliefs and how that made him feel both emotionally and how he reacted behaviourally by avoiding a whole range of situations. It makes me feel really good actually, and it gives me a tremendous source of satisfaction that actually by relating to somebody, by understanding somebody, that you can actually empower them and help them recover. Without the benefits of professional help, Graham would still be stuck at home, he would still be experiencing rather distressing voices.
That is the end of part B. Now look at part C. Part C. aspects of their work. For questions 31 to 42, choose the answer A, B or C, which fits best according to what you hear. Complete your answers as you listen. Now look at Extract 1. Extract 1, questions 31 to 36. You will hear an interview with a dietitian called Ben Melrose, who's talking about iodine deficiency. You now have 90 seconds to read questions 31 to 36. My guest today is a dietitian called Ben Melrose, and today we're going to be talking about iodine deficiency and some of the medical consequences of that. Ben, iodine is a trace element that's found in many foods. Why do some people not get enough?
Well, in some parts of the world, this is an endemic problem. And it's not a question of dietary choice. We get iodine from various sources, like there's iodine in eggs and dairy foods. But by far the biggest source is the ocean. Fish that live in salt water and plants that grow in that environment are our main source of iodine. So we see relatively few cases of deficiency in Europe, for example, because such foods are plentiful there. But elsewhere, typically in the middle of large continents, it's a different story. There, people simply don't have access to sources of natural iodine. Obviously, poorer people in those regions are most likely to suffer deficiencies, but everyone's affected to some degree.
And the consequences of iodine deficiency can be quite serious, I imagine.
Yes, classic symptoms are things like muscular weakness, not being able to focus on the task in hand, and also a tendency to feel cold, even in hot weather. But the most widely reported symptom is actually a feeling of constant tiredness. Of course, there are tests that can determine the level of iodine in the body, and 150 micrograms is regarded as the minimum daily intake needed to avoid symptoms. And there are related conditions. A typical one is an enlarged thyroid, what's often called a goiter.
So you've worked in South America then, where I think it's quite common to see patients with a goiter.
That's right. The case of one of my own patients illustrates this very well. Let's call her Mirabelle. Mirabelle's a middle-aged woman whose home is high up in the Andes Mountains. She lived in Europe for a number of years, where she enjoyed a varied diet and good health. When she and her husband went back to their native country, however, they returned to a remote region and tended to revert to the local cuisine, which is lacking in iodine. As they hadn't suffered any of the symptoms of iodine deficiency before they left for Europe, they didn't feel any particular need to worry about their diet now.
But I believe she developed a goiter.
Well, what happened was she started to have problems sleeping. She'd wake up in the middle of the night with discomfort in her legs, and then she started to get a sore throat. At first she assumed it was flu, but the symptoms persisted. Then one day she noticed a slight swelling on her neck. At first she couldn't believe it. The family were eating lots of river fish and fruit, so a diet that was healthy enough in many ways, but crucially lacking in iodine. Knowing this, she'd been taking multivitamins since her return, so was initially skeptical until a test confirmed that this was the cause.
So, were you able to help Mirabelle?
I was able to work out a diet for Mirabelle that made the most of the natural sources of iodine that were available to her. I also encouraged her to eat Brazil nuts. These are a good source of selenium, which actually helps the body to absorb the traces of iodine which are present in other foods.
Oh.
I also advised her to steer clear of certain processed foods, like bread made with flour improver, because these actually impede the body's ability to absorb iodine. I left it up to her whether or not she continued with the multivitamins.
So, what conclusions do you draw from Mirabelle's case?
What it made me think was that millions of people on this planet must be existing on the brink of iodine deficiency, and that's a cause for concern. Like Mirabelle, when you're young, the body can cope, but this takes its toll with time. Another thought I had was, did Mirabelle become more susceptible to the effects of iodine deficiency as a result of the iodine-rich diet she'd enjoyed in Europe? I couldn't say, but that certainly seems to warrant further study.
Now, look at Extract 2, questions 37 to 42. You hear the doctor giving a lecture on colon polyps and its treatment. You have 90 seconds to read questions 37 to 42. A colon polyp is a tiny growth of tissue projecting from the lining of a section of the large intestine called colon. Polyps are common and occurs as people age. Usually, colorectal polyps in the rectum or colon occur in 30% of adults above 50 years in the U.S., while in children, colorectal polyps occur with an estimated 6% affected to 12% in those who experience intestinal bleeding. Although most colon or bowel polyps are harmless, some polyps develop as cancer that takes many years to turn cancerous. The most common types of polyps are hyperplastic polyps and edematous polyps. Usually, hyperplastic polyps or inflammatory polyps are harmless and not a cause for severe concern with a low malignant potential. Rarely, these polyps become cancerous. Although edematous or edematous polyps are not cancerous, they are potential enough to become cancerous in the future. Larger edematous are more likely to become cancerous. Resection of edematous polyps is usually recommended. Malignant polyps contain cancerous cells. The best treatment for malignant polyps will be based on the severity of the cancer and the overall health of the patient. The symptoms of colon polyps are: rectum bleeding is the most common symptom of polyps, though it can also be a sign of other conditions, such as minor tears in the anus or hemorrhoids. Large polyps that block the bowel movements partially can cause abdominal cramps and pain. Heavy bleeding from polyp can make the stool appear black, while minor polyp bleeding can cause red stripes in the stool. However, other factors such as medicines, foods, and supplements can also cause a change in the color of the stool. If a polyp bleeds slowly over time, it may cause an iron deficiency in the patients. Usually, iron deficiency, called anemia, causes pale skin, weakness, shortness of breath, fainting, or lightheadedness. There may be a change in bowel movements lasting longer than a week, including diarrhea or constipation. Eating too much of red meat may cause the risk of colon polyps. Although etiology of colon polyps is not yet known, their occurrence may be connected with certain lifestyle factors, such as a high-fat diet, eating too much red meat, not including adequate fiber in the diet, smoking, obesity. Genetic factors can also cause the colon cells to multiply over and above and form polyps in certain individuals. Certain individuals are more likely to develop colon polyps if they have inherited conditions, such as familial adenomatous polyposis, Gardner syndrome, or Peutz-Jeghers syndrome. Colon polyps are usually removed by the following methods. In the colonoscopy procedures, a cutting instrument or an electrified wire loop on the end of a colonoscopy is used to perform a polypectomy. However, smaller polyps are raised and isolated from the surrounding area for easier removal by injecting a liquid underneath the polyp. In a laparoscopy, a small incision is made into the pelvis or abdomen. An instrument called a laparoscope is inserted into the bowel. This technique is used to remove very large polyps or if the polyps cannot be removed safely by colonoscopy. Removing the colon and rectum. In this procedure, called a proctocolectomy, is only performed when the patient has severe condition or cancer, in which the colon and rectum are removed surgically. This method is suggested for patients with rare inherited conditions, such as familial adenomatous polyposis that causes cancer of the colon and rectum, and polyp removal may prevent further development of cancer. This is the end of Part C. You now have 2 minutes to check your answers.